So I'm just going to read a few things about Will and then we'll hand over. So he's an NHS GP with a special interest in persistent symptoms and functional illness. He works within the long COVID service at Cambridge and Peterborough NHS Foundation Trust. He has a podcast, which I found on Spotify, called Cambridge Progressive Medicine, supporting people suffering with chronic conditions. He's a cyclist because he's not hiding it very well. That's a real bike in the background. I know he's a dad to two young kids. He's generally an overall good egg. He's volunteering his time for us today. So thank you very much, Dr. Will, and I shall hand over to you.
Thank you very much, Dan. That's a very kind introduction. So the talk today is about how do we know if a symptom is a mind-body symptom? And in order to understand how we know if a symptom is a mind-body symptom, we first need to know what is a mind-body symptom. Now, normally when I give a presentation or a talk about mind-body medicine, this first slide would be about 90% of the talk. But when Sarah asked me to come and talk to Living Proof, I figured that actually most of you guys here have a pretty good idea in your own minds what a mind-body symptom is and what we mean by that. And perhaps it would be a time for the advanced class. So we're going to very briefly touch on that. That said, though, although I am sure that most of you do have a good idea for yourselves, if we were to start debating it and really getting into the weeds, we might find that each of us have a slightly different understanding of what we mean by a mind-body symptom. And that's possibly reflected in the fact that there are so many different terms floating around for these kind of conditions. Now, in this talk, I'm going to use the term functional symptoms and functional illness. The reason for that is because this talk's sort of coming at this from a medical perspective, because we're talking about medical diagnosis. And I think in the medical community, at least in the UK, this is the most widely used and understood term. Now, personally, I'm not that fussed about exactly which term we use, because my belief is that all of these terms are essentially trying to describe the same basic type of problem or type of condition. Even the really ancient terms like hysteria that are obviously very out of favor now, actually they're just trying to explain the same thing. But it's a little bit more than just semantics, because the reason some people are very attached to certain terms and we can't agree on which term we want to use is because some of the terms have a sort of different, slightly different theory or a different idea behind them, and that's reflected in the name that we choose. And so that we're all starting off on the same page, I'm just going to very briefly touch on two simple models that I use most frequently when I'm describing to patients that I see what the difference is between a functional symptom and what we call an organic symptom. And understanding that's going to help us understand how we can tell then clinically which type of problem we're dealing with, and also why that matters. Could I have the next slide? Sorry, I'm trying to move the slides with my mouse. So this first model I call the laptop model, and this was developed predominantly by the neurologists when they were trying to explain to their patients what the difference was between a condition called functional neurological disorder, FND, and an organic neurological condition like a stroke, for example. And the way they do that is they say, well, imagine if you got your laptop and it just won't turn on. Broadly speaking, there could be two major types of problem that's caused that. It might be that you've spilt your cup of coffee over it and you've fried all the wires. And that's a problem with the structure of the laptop. It's a problem with the laptop's hardware. And in that case, if you unscrew the top of the laptop and have a look inside, you'll be able to see all the fried wires. But on the flip side, and equally, or if possibly even more likely, your laptop won't turn on because it's developed a computer virus. So it's got an internal problem with its internal programming, and we call that a software problem. And in that case, if you unscrew the top and have a look inside, it will look completely normal because you can't see those internal programs. And what the neurologists were one of the first people to realize is that humans are exactly the same. So we have our hardware, we have our muscles and our heart and our blood vessels, but we also have internal programs that are controlling all of our body systems. So there's a reason why our heart beats at 50 beats a minute while we're sitting quietly watching the telly, and 120 beats a minute when we're nervous doing a presentation, and talking fast to get it into 25 minutes. And equally, there's a reason why your bowels are moving very slowly sitting on the bus and much more quickly when you're sitting on the loo after a big meal. And there's an internal software program that's controlling all of those systems. And we know those exist because we function as human beings. And because of Sod's law, if something exists, we can know it can go wrong. And what we realize is that very frequently with humans, it does go wrong. And just like with the laptop, if you unscrew the top and have a look inside, so for a human, that would be doing a blood test or taking an X-ray or doing a scan. It looks completely normal. You can't see anything wrong because you can't see that internal program. And traditionally in medicine, what's happened is we've done those tests and we've said, oh, we can't see anything wrong. And that's been translated into, well, there isn't anything wrong. And of course, we understand that's completely the wrong way to understand this. There's something very real that's wrong, but it's at a different level of the problem. That doesn't mean it's not real. If your laptop won't turn on because it's got a computer virus, it's not just stressed or a hypochondriac. There's a very real problem there that needs addressing. So next slide. I keep trying to drive the slides. So this second model. So very specifically, very often when we talk about functional symptoms, it's not just a problem with the software. It's a problem with a very specific part of our software. And this model is this warning system model. So what it recognizes is that symptoms serve a purpose. So the symptoms aren't just random, they're there to keep us safe and they're there to ensure our survival. And we know that if you are not able to feel symptoms, you're not very healthy. So, for example, in the disease leprosy, you remember Robin Hood, Prince of Thieves, you get the guys losing his limbs. So leprosy doesn't actually cause any damage to your limbs at all. What it does is wipe out your pain system. And then because you can't feel any pain, then you get recurrent injuries. And then you, as a result of those recurrent injuries, you do lose limbs. Before we knew how to treat leprosy with antibiotics. So we know that your warning system is an absolutely essential part of our survival and required mechanism for our well-being. But again, because of Sod's law, if a system exists, it can go wrong. And what we understand is that sometimes when you're getting symptoms, it's because of a primary problem with that body's internal warning system. And the way I always describe this to patients is that you imagine you're driving along in your car and your oil light comes on. So you dutifully take it round to the garage and they have a look at the engine and they look at they say the oil's absolutely fine. Well, it might be that the problem is a short circuit in the light. And just like with the laptop example, that doesn't mean it's not a real problem. It doesn't mean that you're hallucinating, you're imagining the light is on. The light is really on, it's just as bright, it's just as distracting. And there is a very real problem with your car. It's just that the problem isn't in the engine, the problem is with that warning system itself. Now, the ways that the warning system can go wrong is very, very complex. And that's perhaps why there's so many different terms for mind-body medicine and why different people have a different way of approaching this. We're not going to get into that here. I'm sure many of you have good ideas about that. But for me, this mantra here is, if the brain thinks we're in danger for whatever reason, it will produce symptoms. And we think about that the warning system becomes stuck on or hyperactivated. And is therefore, instead of protecting us, is actually making us ill. So we move on to the next slide. Thank you. So how do we know? So we've got these two the problems. You've got a problem with the structure of the body, like the engine of the car, or you've got a problem with the internal programming. And how can we tell which is which? Now, historically, we've kind of had this concept that these are what we call a diagnosis of exclusion. And I call this the bargain bin diagnosis. So you do all the medical tests and anything that doesn't seem to fit with what we knew before, we stick into this bargain bin. Now, I think that's a very bad way of practicing medicine. I think it gives a very erroneous message about the nature of these conditions. And I think it can lead to people feeling like they're being dismissed or the problem is not very serious. And we're very much moving away from that towards what we call making a positive diagnosis. Now, I don't mean by this that it's a good thing you've got it. I mean that you're positively identifying what's going on. And we can do that just as like we do with the rest of medicine based on the pattern of the symptoms, so what we call the presenting history, but also the previous medical history, the history in the family, risk factors, what we call predisposing, precipitating and perpetuating factors, and also examination findings and appropriate medical investigation. So we can approach these conditions exactly the same as we do with any other medical condition. And so we go for the next slide, if that's okay. So this is a framework that was created by a guy you probably recognize in the bottom right corner here, Howard Schubiner, who is the OG of mind-body medicine. And he came up with this framework for recognizing patterns of symptoms that are suggestive of a primary software problem. And he calls it the FIT criteria. Now, the first part of that is functional. So what that means is that the symptoms don't follow a pattern you would expect from a hardware problem. They look like a software problem. And so if we take that example we had from before of the oil light, if you take your car to the garage and you say, my oil light's on, and the mechanic says, oh, what's it doing? And you say, well, every time I beat my horn, it comes on. Or you say, well, it's flickering on and flickering off again. And the mechanic might think, well, that doesn't really sound like an oil problem, because there's not really a physical way the oil level could be related to the horn. And it'd be very unlikely for the oil to be filling up and disappearing and filling up and disappearing. So it doesn't look like it's a problem with the hardware. But actually, a warning system problem can turn off and on very quickly, and it can follow these unusual patterns. And in a human, the sorts of things we might see would be, for example, symptoms always occurring on one side of the body, but lots of different symptoms. So if you get a headache, it's on the right side. If you get weakness, it's all on the right side. If you get itching, it's all on the right side. So different symptoms, different types of body systems, all occurring on the same side, which wouldn't normally happen in a physiological way. The other thing would be, well, we'll talk about those in a moment. So the next part of it is inconsistent. So these are symptoms that are varying and coming and going in a way that wouldn't really make sense in a structural way. So your warning system can turn on like that. If your brain thinks you're in danger, bang, it can come on. All right. So whereas things that are happening in the body tend to happen much more slowly. So for example, if you have pain that's starting in a knee and then it rapidly moves to a shoulder and then it moves across to a hand, in this kind of very rapid way, that's quite suggestive of a warning system or a software problem as opposed to a hardware issue. And then the final part of the fit criteria is triggered. So these are symptoms that are being brought on by various stimuli, often a wide range of different triggers that you wouldn't expect to actually be causing the symptom in a mechanical way. And a very common example of this would be things like food allergies. So very often with functional illnesses and functional symptoms, people will become intolerant to lots and lots of different things that are triggering the symptoms. And it's not actually a chemical allergy, it's more a learnt pattern, a learnt danger pattern in the brain. And again, my favorite example of this is that lots and lots of people have a kind of alcohol that they can't touch because when they were 15, they went to a party and had way too much of it. So for me, it's tequila. And if I smell tequila, I feel physically sick. And I'm not allergic to tequila, but my brain says, have I come across this substance before? Yes. What happened? Well, you're underneath the hedge at the bottom of Matthew Neville's garden, and it turns on the nausea. So these patterns of triggered symptoms that often will expand to lots and lots of other things that are triggering it, again, are very suggestive of a warning system problem. Can we have the next slide? Is that okay? Thank you very much. So this is a kind of general framework that Dr. Schumann had put together, but actually what we see in clinical practice is that there are some distinct patterns that you see that are kind of common clues that help me as a doctor to start thinking, yeah, this is looking like it's a software problem. The first one is unusual symptoms. So in medicine, we learn about all the hardware first. So pretty much everything I learned about in medical school is hardware. And that's because the hardware is much simpler and it's easier to understand. So we learned about that first. And the neuroscience that's helping us to understand the software is sort of new neuroscience that's only just coming. And that hardware, because we sort of know about it, we taught about it in medical school, we're used to the types of descriptions. So a heart attack is described as like weight on the chest, and doctors are used to hearing those. Now, what happens with the software problems is that you can get very atypical descriptions that don't really fit with that stuff we learned in medical school. So sometimes my patients come to me and say, when I told the doctor my symptoms, he looked at me like I had two heads. Now, what I'd say is, if the doctor's looking like you've got two heads, number one, that's their problem, not yours. But number two, it may well be because these are a software problem and the doctor's not used to hearing them. Sometimes what you get is very, very poetic descriptions of symptoms, which you tend to see be less common when there's organic or hardware problems. So, for example, like I had a patient says to me, my fatigue's so severe it feels like my eyes are sitting on my cheeks like a basset hound. Or you have people that say, I feel so exhausted, it's like I'm walking through treacle. I had one patient who just said, the pain feels like a musical chord through my body, but with half the notes missing. So these very descriptive and poetic descriptions very often can point towards a software problem. So again, we talked about the software patterns. So an example of that, just from a recent example, I had a patient who had a burn when they were a child. And when their symptoms came, the symptoms always originated from this spot of this burn and then spread through the rest of the body. So if you've got these sort of unusual patterns where symptoms are originating from areas of previous trauma, again, that can be a very good pointer. The other thing is symptoms happening only in certain situations. So I had another patient who was having kind of like collapsing episodes, but when we really delved into it, we found it only happened on one particular staircase at work, and it never happened anywhere else. And then when you start exploring that with people and saying, you know, like, why could that happen? Like, if that was a physiological problem, how would that explain that your body only reacts? Whereas if it's a warning system problem, it starts to make sense, and that can really help people to start connecting those dots and understanding, you know, what might actually be going on. Now I've got a note here about post-exertional malaise. I think that's a sort of special thing. I'm sure many of you will know about post-exertional malaise, which is where you get exertion triggering a period of severe fatigue or malaise. Now, I think this is a hallmark feature of a functional symptom. It's a little bit controversial because it's also a hallmark feature of ME/CFS. And some people say that if you don't have post-exertional malaise, you can't have a diagnosis of ME/CFS. In my experience, PEM is actually a little bit of a misnomer, because for me, it's rarely actually about just exertion, and it's rarely about just malaise. What it's more about is boom and bust. So it's about these periods of relative improvement in symptoms and then triggered periods of severe, like increased severity of symptoms. And actually, the reason I think it's a misnomer is because it's not just exertion that triggers it, and it's not just malaise that it's caused. So what I tend to see with patients is that there'll be a wide range of things that can trigger the symptoms. So for example, mental fatigue might be triggering mental exertion might be triggering physical fatigue, or it may be that, you know, somebody is triggered when they have a certain meeting at work, and each time that triggers the symptoms. The other thing that can be a pointer is if there's very clear cutoffs. So sometimes I see patients and they'll say, you know, I can walk a kilometre and I'm fine, but if I go 100 metres over that, all my symptoms will be triggered. And for me, that's very much a sign that this is probably a warning system problem, because what's happening is that the brain is saying, here is the danger threshold. You go a tiny bit over that danger threshold, it triggers the danger. Whereas physiologically, if we were thinking about, for example, mitochondrial things tend to be much more on a, you know, you don't tend to get these big cliffs and big cutoffs. And then the last part of that is all of the symptoms coming together. So during a crash, it's not just fatigue, but all the various symptoms that people are experiencing come all at the same time. So when they get a trigger, their dizziness comes, and the nausea comes, and the fatigue comes, and the brain fog comes. And when all of those different symptoms from lots of different body systems come together, again, for me, that's a sign that this is a warning system problem, because the warning system controls all of your systems, right? Whereas in the hardware, each system is it's not completely separate, of course, but you tend to see, let's say you have a stomach problem, you tend to get stomach pain that is triggered when the problem is triggered, not with all the other symptoms. And then there's some specific symptoms that are very, very suggestive of software problems. So for example, fizzing, tingling, burning, sensations of twitching or jerking, but when you know your friends or family wouldn't notice, or you look in the mirror, it looks normal. Dissociation or unrealness, so these sort of out of body feelings. People saying, you know, I'm always veering to one side after the right, over either the right or the left. These are quite common symptoms that we see that tend to be more common with software problems. But that said, like any symptom, so any symptom on its own can be difficult to interpret. What we normally would do in medicine is we take the symptoms in the context of the patient, and that's very important. So can we have the next slide? Is that okay? Thank you. Yeah. So what we tend to see with functional symptoms is lots of symptoms. So that's often the first clue. So you get multiple symptoms in multiple different body systems. Now, when Sarah and I first talked about this session, the original thing was we were going to call it which symptoms can be mind-body symptoms, but I didn't feel that was quite right, because actually any symptom can be a mind-body symptom, and the reason for that is that all symptoms are produced by your brain, right? So that's what symptoms are. So all symptoms are produced by activated warning systems. So if your warning system is activated, it can literally produce any symptom that you can possibly imagine. And what happens is that actually it does, right? What tends to happen is if the warning system's activated, it starts producing symptoms across all these different systems. So people end up getting lots and lots of symptoms. I've listed some very common ones there. So it can be any. Some are more common than others. Fatigue, brain fog, joint aches and pains tend to be the main most common ones, but it can be anything. So next slide, if that's okay. Thank you. So yeah, so if we have lots of symptoms, we tend to get lots of diagnoses. So in the past medical history, very often I'll see patients and they will have collected a lot of different diagnoses over the years. And when you see that pattern, it can be quite suggestive that there's a warning system problem. And what I normally say to my friends is actually, you haven't got 3 or 4 different diagnoses. There's an underlying problem which is creating symptoms in lots of different body systems. So we think about this as one diagnosis causing lots of different symptoms. Now I'm not going to go through this list here, but I just very briefly, the ones that are on the left hand side, these are conditions where pretty much we think these are definitely warning system problems. The list on the right is a little bit more controversial, where we don't fully understand the pathophysiology for some of these conditions, but we think it's very likely there's a significant components of activated warning systems contributing to the symptoms. Next slide, if that's okay. We've got 5 minutes. We're talking faster and faster. So then we think about risk factors. So, you know, in normal medicine, in all medicine, like if a patient comes in, they're a lifelong smoker, they've got a family history of heart disease and they've got central chest pain, I'm going to say, well, maybe this is a heart attack. And it's exactly the same with functional symptoms. So if we see people, you know, we know the kinds of things that can cause activation of the warning system, and if you see those in the history and in the past, then that can raise your suspicion that there might be a functional problem, a warning system problem. So that includes family history, parents with these types of diagnoses. Adverse childhood experiences are extremely important. I'm sure you guys all know about personality types already. You know, these types of personality types that make it more likely. And then also life stresses. It's not just childhood trauma, but things that have triggered the symptoms. And actually, when you really dig down into people's histories, it's amazing the incredible, you know, the incredible trauma that comes out. So very recently, I had a patient and he had chronic fatigue for 15 years, and we had a chat about it, and it turned out it had all started when he'd seen a car go into a Fenland dike in February, and he dived in after it to try to save the people, save one of them, and then drowned, passed out from the cold, and had to be resuscitated. And then all his symptoms started after that. And you know, this is the first time anyone had sort of linked that massive traumatic event to these symptoms that had started coming afterwards. And then we have what we call the perpetuating factors. So I said Howard Schubiner shows up everywhere. Howard Schubiner talks about these 5 Fs. So these are things that people do naturally. So it's not a blame thing. It's just what humans do when they're ill to try to deal with the illness, which unfortunately, if the problem is a warning system problem, cause a positive feedback and further activate the warning system. I'm not going to go through them right now because of time, but if you've not come across the 5 Fs before, highly worth checking those out. Next slide, if that's okay. Very good. So then, like all medicine, what we do is we take a history, we look at the family history, we look at the pattern of the symptoms, and we form what's called a differential diagnosis. So you make a list of things that you think could be causing that symptom. So if somebody comes in with chest pain, I'll make a list. What can cause that? Pneumothorax, heart attack. It could be a warning system problem. And the order of that list depends on what the other risk factors are and what the pattern of the symptoms look like. But then that's never 100%. So then what we need to do is we need to confirm that diagnosis with appropriate medical examination and medical investigations. Now, there are actually some specific investigation findings you can see in warning system problems that you only see in warning system problems. I'm not going to go into them here again because we've got 2 minutes, but on the right here, this is called Hoover's sign. And on the left is my favorite medical sign of all time, which is called extended slinky sign. And you only see this with functional tremor. So when you've got a warning system tremor. And then if like you do your examination and then you need to select appropriate tests, and that's incredibly important. So it's very important that you have the appropriate medical test. If I see a patient who's got chest pain and they've got a family history of trauma and the chest pain's a little bit atypical, and I do a heart tracing and it shows they're having a heart attack, then I need to reshuffle my diagnosis. So it's really important to get those medical investigations. What I would say is that in functional symptoms and illness, a negative investigation test can be a positive finding. Because as I said at the beginning with the laptop, if you look inside with a functional problem, with a software problem, you don't see anything wrong. But sometimes that can be a positive finding, because if I do that heart tracing and it looks completely normal, that may confirm and clinch the diagnosis. Very briefly, the one thing I would say to be cautious about is what we call incidentaloma. So if you do a test, sometimes you can find something that's wrong that may or may not be related to the symptoms. So that's a little caveat, but that's, well, it's about good medicine. So if we go to the last slide, I think we're on the final one. So I've got 30 seconds for the last one. So I thought I'd just very briefly touch on what we call red flags. So a very common concern I have from patients is that once they've been given a diagnosis of a functional condition, like fibromyalgia or chronic fatigue, they worry that then every time they go to the doctors, they just say, oh, well, it's because of the chronic fatigue, oh, it's because of the fibromyalgia. And they sort of worry that that's sort of trying to ignore the symptoms. So, well, it's chronic fatigue, so just ignore the symptoms. Now, I just wanted to really highlight that's not what this is about. It's not about ignoring the symptoms. It's about recognizing the patterns of the symptoms and making that positive diagnosis. And each time symptoms come up, we need to reassess that, because people can have more than one thing. So just because you've got type 1 diabetes doesn't mean you can't get hypothyroidism as well. And actually, it makes it more likely that you get hypothyroidism. And the same is true for functional symptoms. So what I would say is if you're getting new symptoms that are abnormal or not of the usual character for you, then you need to see your GP and get things checked out. And that's what your GP is there for. And there are just a couple of specific symptoms I'd say that are quite rare in functional illness. They can occur, but I would say that if these were occurring, even more so, it definitely needs to be checked out. And they're just sort of listed briefly there.